Welcome back to 12 Days in March. In this video, recorded during a live lecture, I will present a categorical approach to the vasculitides. And let me be clear about this. Each of the topics themselves require more detailed explanation that will be offered during subsequent lectures, but the purpose of this overview is so you can develop a mental construct of this very large and nuanced topic. So let's get started.
All right, so I thought about best way to do vasculitis. It's better to just have the framework for vasculitis before we do the questions. And you know what these pictures have to do with vasculitis? Absolutely nothing. I just think they're pretty. All right, here goes. There's the classification. Large vessel, medium vessel, small vessel. I understand the Chapel Hill criteria. It does include large and medium vessel. When it gets to the small vessels, it mixes things up a little bit. You're going to get the Sachs classification, not Chapel Hill. So all you need to know, here's your two large vessel, and they're both granulomatous. The derivatives on the large vessel vasculitis are going to be related to granulomas. Giant cell arteritis, also called temporal arteritis, has that association with PMR. So here's your two large vessel, medium vessel, Kawasaki, very classic. Polyarteritis nodosa is the one they seem to like and come back to a fair amount. So you should be very familiar. Temporal arteritis is going to be associated, just an association with PMR. Why it's associated is unclear, but PMR is going to be a gateway to temporal arteritis. This is one of the places I talked about. Osteoarthritis is going to have a normal SED rate. Giant cell arteritis, temporal arteritis is going to have the elevated SED rate. And I say blindness. What's supposed to happen is it's ophthalmic artery involvement and you should lose your vision. But just pay attention to 72-year-old with ocular symptoms as a manifestation of temporal arteritis. As far as Takeuso, young Asian with a pulse deficit. Now, let me tell you something. This only goes in one direction. If they happen to give you a young Asian and they don't have a pulse deficit, don't be thinking Takeuso. Medium vessel. So PAN, they love the description, the pathologic description, fibrinoid necrosis with a transmural inflammation. You promise you have that? So the 20 questions I give you that all say fibrinoid necrosis with transmural inflammation, you'll know that's PAN, right? And then, what they then do, it's still multi-system, GI, neuro, skin, but they love this association with hepatitis B. So these are the notes you have to have on polyarteritis nodosa. I just made that so simple for you. That's it. And then Kawasaki, there are 5 manifestations. Eye involvement, so conjunctivitis, mouth involvement, the strawberry tongue, fissuring of the lips. You get the desquamating or erythematous rash of the hands, cervical lymphadenopathy, and fever. It's a syndrome. Those are the 5 criteria. That's all they can do with Kawasaki. Every Kawasaki question has all 5 of those features. And you can see here this adorable little child I met in clinic the other day who presented with Kawasaki disease. Eye involvement, mouth involvement, strawberry tongue, fissured lips, cervical adenopathy, fever, and look at that desquamating rash he has there, or erythematous rash. That's Kawasaki, okay? I know, you wish you could adopt that baby. And so, generally speaking, what else do they do with Kawasaki? What's the complication? Coronary artery aneurysms. I mean, it's black and white. This is a no-brainer. We're not going to miss Kawasaki questions. Small vessel is torture. There are a million of them. But with the Sachs method, we totally nail these, and we'll just start with lots of A's. So we have the ANCA-positive vasculitides, right? A, ANCA-positive. So we have P ANCA, C ANCA. The P ANCA, perinuclear staining, is microscopic polyangiitis, which is generally a distractor. It's not usually the answer. And Churg-Strauss, all Churg-Strauss has eosinophils. And granulomatosis with polyangiitis, C ANCA. C ANCA is also proteinase-free, right? So PR3 positive. They use those terms interchangeably. So we have our ANCA-positive vasculitides. This is not really an ANCA negative, but wherever there's GPA Wegener's, there's always good pasture right on its heels. So I keep those kind of clumped together, small vessel vasculitis. So good pasture Wegener's, they travel together, ANCA positive, ANCA negative. And then we have one other A is IgA vasculitis, and it is a vasculitis. IgA vasculitis travels as henoch-schönlein purpura with the 4 organs involved. And then there's just 2 other classes, right? So toxin-associated, and the toxin-associated, basically drugs, leukocytoclastic vasculitis, nicotine-related. So that's Berger's disease, thromboangiitis obliterans. It's not really a vasculitis, but it comes up with the vasculitides. That's where you see those questions. And then finally, the multi-system association. Sarcoid is on the list as well, other autoimmune diseases. But again, the vasculitis is not going to be a prominent feature of these. They're going elsewhere on multi-system associations with vasculitis. So I'm taking that right off the list, and now we're just left with these, and these toxin-associated are going to be pretty classic. So right up here is the confusion compared to also the medium vessel vasculitides. IgA vasculitis with nephritis, that's a formal classification. IgA vasculitis with nephritis, formerly Henoch-Schönlein, but I still like Henoch-Schönlein purpura because the purpura gives me a clue already, palpable purpura. On the buttocks, on the legs, okay, and they're palpable. It's vasculitis. You can feel these things as opposed to bruises. You can have joint involvement. There's MSK, right? So you have a periarthritis, not a true arthritis. It's an arthralgia with kind of inflammation around the joints, but not from the joint. We remember from renal IgA nephropathy. We love that. The renal involvement with IgA nephropathy is the same seen with this IgA vasculitis. And bowel involvement, that bleeding or abdominal pain, they go both ways on this, and it's truly a vasculitis of the bowel. Henoch-Schönlein, purpura, 4 criteria. All 4 will be present in HSP questions. Okay, so we have that one off the list. Now we're coming to these two. So Wegener's and Goodpasture's do travel together. They will all, for the most part. Occasionally you'll get just an anti-GBM question that just has renal involvement without pulmonary, but those will be pretty straightforward that way. So it's really the pulmonary renal syndromes, pulmonary and the renal part. The renal invariably is crescentic. Crescentic or rapidly progressive glomerulonephritis, azotemia, high BUN creatinine. Okay, so those kind of stand out uniquely, and you ultimately have to make a distinction between them both. Churg-Strauss, you get this, all this pink color, that means eosinophils. So Churg-Strauss, the other name for it is eosinophilic GPA, granulomatosis polyangiitis. So it has pulmonary involvement, asthma and or upper tract involvement, perhaps predating the syndrome. But you get renal involvement, same thing, rapidly progressive glomerulonephritis, multi-system, skin involvement, neuropathy. Key thing here, it is P. ANCA positive, but these are going to just stink of eosinophils. If they give you a question and it's a vasculitis and there are no eosinophils, it is not Churg-Strauss. It's an eosinophilic vasculitis. I like that description of it, and that the inflammation is around the vessel or in the vessel wall doesn't really matter to our discussion. Mpa Microscopic Polyangiitis. So it's P. ANCA, and it actually behaves like PAN. So it is a necrotizing vasculitis. It does not involve the upper respiratory tract, compared to C. ANCA, GPA, Wegener's, involves the upper respiratory tract. They're both ANCA positive, one's P. ANCA, one's C. ANCA. Key thing, they won't ask this, but you do need to understand that the P, perinuclear, refers to myeloperoxidase. And the perinuclear just has to do with the negative charge, how myeloperoxidase lines up with the nucleus. It's a staining artifact. But the myeloperoxidase, the ANCA of myeloperoxidase, is pathogenic in Mpa, microscopic polyangiitis, whereas the C. ANCA in Wegener's is not pathogenic. Proteinase 3, ELK, lung, kidney. E is ears, eyes, nose, and throat. It's just upper tract involvement. But if they give you ear or eye involvement, it can still be Wegener's. Thromboangiitis obliterans, again, it's not a true vasculitis, okay? And the name gives it away. Thromboangiitis. Thrombus first, phase 1, that's what happens in the vessel. Then within the vessel, that thrombus gets inflamed. So you have angiitis of the actual thrombus within the vessel, and ultimately kind of fibrosis and blocks the circulation, phase 3, obliterans. But it's inflammatory disorder essentially within the vessel that ultimately extends beyond that. And that's the other sleeper. So in terms of segmental, many of the vasculitides just give you segmental involvement, but what's important for thromboangiitis obliterans is this contiguous involvement. So the thrombus gets inflamed, it extends beyond the vessel walls, can involve the nerves, so there'll be paresthesia, numbness, but also involvement of the vein, and they like this as a distinguishing feature of thromboangiitis obliterans. Obviously, you need nicotine exposure. And lastly, leukocytoclastic vasculitis. So this is really just vasculitis limited to an organ. It's limited to skin. These patients, these are all drug associated. This is the one you're most likely to see. You give patient, choose your favorite drug or antibiotic. They come in and say, what is this? 10 days later, And it's like, oh, you got leukocytoclastic vasculitis, and really cool, but it's a skin disorder. It doesn't involve multiple organs, so it's not all that exciting. You need to know that the pathogenesis of this is immune complex deposition. So here's immunofluorescence staining these immune complexes deposited in the vessel walls, and it really can be pre or post capillary. But I've seen in the Q banks and BME where they describe it more in the post-capillary venule. So if they ask, that's your answer. So leukocytoclastic is you get breakdown of white cells in the vessel wall, secondary to immune complex deposition, predominantly post-capillary venule if they ask. And I think that's my overview.
And that will do it for this overview. In subsequent presentations, we will get into the weeds on the individual topics. This presentation was offered to help organize your thoughts when you stumble upon a question that has the smell of vasculitis. As always, if you have any questions or concern, please email me at 12 days. Good luck.